Good morning, friends and colleagues from across the world. Welcome to the 39th day of the 2020 Peer-to-Peer Global Dental Interdisciplinary Summit. 12 hours ago, we were in Japan, and now we are back in Israel with a very, very special guest. Many of you guys know from his beautiful presentations in many, many countries and many, many dentists that he has trained over the years. We have Dr. Nitzan Bichacho from Israel, hosted by Dr. Joseph Nina Atala, our regent. Thank you for joining us, gentlemen.
Thank you very much, Kenur. Thank you, Joseph. And
it's a pleasure, Doc.
Good morning, good evening, wherever you are, everybody.
Thank you.
Thank you. So with that said, we have 6 more days left of this interdisciplinary summit. You guys can daily watch the complimentary webinars on Facebook at Global Summit. For those that are interested in CE, they can go onto our website and register for that. There's some additional steps in Q&A. And we look forward to a grand celebration with you, as we are now aiming no longer for 1 million, but we're aiming for 1.5 million of our colleagues. That shall be there by Sunday. So with that said, Dr. Atala, you have the floor.
Good morning, everyone. Today is one of the most exciting days at the GIS. We have Dr. Nitzan Bichacho himself. So, Dr. Bichacho, it's a great honor, and we're very happy and very excited to have you today. I'm going to go through the credentials very quick of Dr. Bichacho so people can know more about him, and we'll go from there. Dr. Nitzan Bichacho holds the post of expert in prosthodontics at the rank of professor at the Faculty of Dental Medicine, Hebrew University at Hadassah, Jerusalem, Israel. He is a faculty member of the Department of Oral Rehabilitation of both dental faculties at the Hebrew University in Jerusalem and at Tel Aviv University, Israel. He is the past president and a life member of the European Academy of Aesthetic Dentistry and serves on the editorial boards of leading international dental journals. Professor Bichacho is a co-inventor of several innovative implant system and is the conceptor of restorative clinical techniques that have become widely used around the world. Professor Bichacho publishes and lectures worldwide in the fields of dental implant therapy, fixed prosthodontics, interdisciplinary treatments, and innovative modalities in aesthetic dentistry. The Bichacho Clinic in Tel Aviv focuses on interdisciplinary treatments and collaborating with world-renowned colleagues and dental technicians. I love your work, Doc, and I can't tell you how excited I am for hosting you today. So welcome again, and we're very excited to see what we're going to learn.
My pleasure, Joseph. My pleasure. Thank you very much for the kind introduction. Should we go for full screen now?
Yes, please.
Well, everything is set?
Yes, Dr. Bichacho.
So let's start. Okay, my friends, colleagues from all over the world. 30 years ago, I was still a young person and a young dentist. And this was actually the first case where I participated in restoring a single implant at the smile zone. So this cracked tooth was removed by my friend, Dr. Kobe Landsberg, the periodontist from Tel Aviv. And after ridge augmentation and ridge preservation, we waited for about 6 months. Then the implant was placed. And 6 months later, I came in and restored this implant. And this was how it looked like a year post-op. Those days, we're talking about 30 years ago, I was very happy with the result, and you will understand in a minute why. Although you can obviously see that there are some discrepancies between the natural homological central incisor and the implant crown. When we go down the road 15 years, we see that the tissue is stable. In the periapical radiograph, we see that the bone stabilized around the first or second thread, and this is how it looks like 31 years after implant placement. So we can see that actually after 3 decades, both the soft tissue and the bone look very stable. And we're very happy to have this result because, as you know, especially 30 years ago, what was considered to be a success was completely different than what we would like to get these days. So if you go back to some very popular articles like this one of Albertson of 1986 with Zarb and some others, what they defined as success when they were describing implant restorations was an anticipated first-year remodeling of the bone of about 1.5 millimeter of bone resorption, and then 0.2 millimeter every consecutive year, which means that after, let's say, 10 years, you would expect to have 3.5 millimeter of bone resorption. And this was considered a success. What they also observed is that the aseptic loosening of bone that was described of 0.2 millimeters might have actually propagated into a contaminated area of the bone, as you can see, after so many years. And this is something that we know that today has been termed peri-implantitis. So we were very happy with that result because, as you all know, this type of situations where you have inflamed tissues, where you have recession of the mucosa around the implant crown, when you have resorption of the bone around the implant, are some things that today we know that might happen in between 20 to 30% of our implant treatments. And this is something that, of course, we need to do whatever we can to avoid. And the question is, what tools do we have today that can minimize this type of tissues instability and tissues contamination? So first, I would like just to describe some things that were definitely changed and evolved throughout the last 3 decades. So if in the 70s, these were the type of implants that we used with external hacks, the surface was machined and not treated otherwise, throughout the years, many different implant systems came into the market. And about 15 years ago, I was part of a team that developed an implant that you all know, the Nobel Active, that actually enabled every dentist to have the implant not only in healed sites, but also in sockets as an immediate implant placement. So immediacy is not something new. Whoever is dealing with implantology knows that immediate implant placement is a well-established concept for more than 15 years. And some years ago, different type of implants were presented to the market, and each one has its own advantages, and we will see later on one of those implants. So whenever we are placing an artificial titanium screw into the living bone, we are looking for a biologic homeostasis. So when I talk about the software now, not the implant is the hardware. I'm talking about the software, which is the natural tissue's response. Then the bone itself is expected to accept this artificial foreign body, the implant, and to live in peace with it, to accept it, not to react in any type of inflammation, and to remodel and to stay there close to the implant in peace. So the question is, of course, is it obvious? And the answer, no, it's not obvious at all. because the software, which are our natural cells in our body, are encoded by God, maybe, if you believe in God, or by nature, to respond and to react in a very distinctive manner whenever a foreign body is intruded into them. So still we are expected the bone to live in peace with this type of titanium implant. Then we have the mucosa, which is a different type of tissue, and the mucosa is expected to live in peace with the abutment or the implant crown that penetrate through it. Now, just remember that this is a very, very interesting area, because this is the junction between the outside world, which is the oral cavity, which is a contaminated area, and the inside world of the body. And of course, in order to prevent the contaminants from the oral cavity penetrate into the body, there should be kind of a barrier that will reorganize around this abutment or implant crown and enable the body to live in a healthy condition and homeostasis. So actually, we are looking for a complete integration of these two artificial components, the implant in the bone and the abutment and crown throughout the mucosa. And this is something that we might have some control over it. If the response of the bone and the mucosa and the other structures to these artificial components is the software, we need to know that, like in any software, there might be some bugs in the software. On the other hand, we might upgrade the software, and we will see how can we upgrade the software, which is the natural response of the tissues towards this type of procedures. We have the hardware. The hardware are actually the implant systems that we use. And we have also the algorithm. The algorithm are the set of actions that we do in order to solve the different problems of the software. What do I mean by that? Well, you might use different implant systems, and this will have an effect on the software response, which means the different implant systems will cause the bone and the soft tissue around it to respond differently. And if we want to have the optimal response of the software, we might need to use better implant systems. And we will see later on what we can do about that. Then, of course, the implant system that you use will actually have an impact on the way that you treat the patient, the different steps that you have to manipulate, whether it is in the bone or the soft tissue. And of course, we are able to choose different clinical steps that will have an impact on the response of the body, on the software. So this triangle is very important in order to understand how can we better achieve stability of the bone and of the tissue in a healthy state along the years. So my presentation today is about trying to share with you the insight that we accumulated throughout the last 3 decades and understand the biologic software that is something that not everybody really understands, and how can we match the right hardware in order to have optimal response, to have better implant therapy. I will concentrate mainly on 3 aspects: on the peri-implant envelope, meaning the bone and the mucosa, on the implant system itself, and on some prosthetic strategies that I believe that are fundamental in order to achieve higher chances for stability in those tissues. We operate in Tel Aviv with a dedicated team of assistants, secretaries, dental hygienists, and this is a small office. It's a boutique type of clinic, and I am very blessed to have two associates, Dr. Galit Talmor and Dr. Mirela Ferrau, two dentists that are outstanding clinicians, outstanding human beings, and very close friends. Mirela is also my personal significant other, my wife, and we operate together, trying to fulfill our beliefs and to be able to let our patients get the best dental treatment that we are able to provide them. Our philosophy is very simple. We believe on logical dentistry. Whatever we feel and know that doesn't make sense, we try to avoid. On the other hand, whatever has been proven throughout the years to be a successful concept or a successful material or a successful system, we do try to implement. We read lots of articles. Many of them have no sense, but on the other hand, I would say that about 5 to 10% of the published articles that we read give us very important information. And most important, we share our problems or our insights with some very close friends from all over the world that we trust. And we know that dentistry is actually a clinical profession. And whatever my friends share with me and I share with them is very important input for us to choose where to go and what to choose. At the end of the day, we try to provide to our patients a healthy ecosystem over time. And of course, when it comes to implant dentistry, when it comes to choosing the right implant system, the hardware, we would always try to choose high quality systems, high quality in terms of manufacturing, in terms of implant design, in terms of cleanliness of the surface, in terms of very, very accurate adaptation of the connection between the abutments and the implants themselves, and things, features like that. So this is for us, the dentist, to choose the right high quality system. On the other hand, we know that a major factor in the survivability and healthiness of the results are the oral hygiene procedures performed by our patients. So these are two main factors that I believe that need to be integrated in order to allow for a healthy long-term result of implant therapy. Now let's talk a little bit about the response of the tissues, the software, when we place an implant throughout the mucosa into the bone. So if this is a situation where we place an implant at the bone level, at the crestal level, and we start with a thickness of mucosa of 3 millimeters or more on top of the implant head, once you connect an abutment to the oral cavity, once you expose this implant, then the tissue will react in formation of biologic width. Biologic width is actually a barrier band of connective tissue and epithelial attachment or epithelial adaptation that prevents contaminants from an oral cavity protruding into the bone. So around implant, we know that the average of 3 millimeters is needed in order to create and to form this biologic width. In such a situation, these 3 millimeters of biologic width on top of the implant will not cause any bone resorption. So the implant threads will stay covered by bone. But if the situation is different, if you have less than 3 millimeters and you connect an abutment or crown, then the formation of the 3 millimeters of biologic width will result in some bone resorption. And this is regardless the implant system that you use. This is a natural response of the body. This is the software that is encoded to respond like that, to have this defense mechanism of barrier. And actually, this is something that you need to take in mind. Why? Because if you know that you started with less than 3 millimeter thickness, vertical thickness of mucosa, and you place the implant at the bone level, then if you want to avoid some bone resorptions when the biologic width is created, you need to augment tissue, to augment connective tissue, and this will be part of your algorithm. Another way is just to place the implant infracrestally. When you place the implant 1 millimeter or more infracrestally, then throughout the formation of the biologic width, the bone will resorb in order to enable this 3 millimeter thickness, but at the end of the process, it will still stay on top of the implant head, so no implant threads will be exposed. This is a different type of algorithm. And the problem is that not every implant enables you to place it infracrestally and let this response happen in a healthy manner. Because when you place the implant infracrestally, you need to be able not to compress the cortical bone, because otherwise the cortical bone will resorb. You need to be able to place an implant that the connection is extremely precise and tight, because otherwise contaminants will come through the abutment to the implant abutment interface and the bone will be contaminated and resorb. So the two conditions to be able to place an implant infracrestally is an implant system that does not compress the crestal bone and very, very precise implant configuration in order to have adaptation of the abutment or any other prosthetic component with no micro gaps. What we know about the buccal algorithm, we were talking before about the vertical algorithm, so you understood what we need. And what we know is that in order to have the tissue stable, long-term, and not recede, or not to let the bone resorb, we need an overall buccal horizontal thickness of more than 3 millimeter of bone and mucosa. And today we know that we don't make any distinction between the bone and the mucosa. You can have more bone and less mucosa, more mucosa or less bone, or sometimes even no bone at all at the crestal level, but very thick mucosa, more than 3 millimeters. And we know that when you have an overall thickness of tissues of more than 3 millimeters, then the whole area will be stable for long term. So we need to be able to create or to preserve this thickness buccal to the implant head. Whenever you see on the screen these QR codes and name and date or year next to it, you can take your phone and click on the camera, and then you will get immediate access to the PDF of the article that I placed here. So for instance, we have here one article from Uli Grunder from 2011 and another article from Uli Grunder and Stefano Grachis and Matteo Capelli from 2005. And if you will click and you will have the PDFs of these articles later on. You can read what they found, and I just summarized to you that the bottom line is try to get minimum 3 millimeters of overall buccal thickness horizontally. We also know that in order to get an aesthetic appearance of the implant crown, you need this volume, because it's not only about the volume, it's also about its configuration. You would like always to have this type of convexity around your implant at the mucosa level, like a root prominence of a natural tooth in the gingiva. So here it's not a gingiva, it's mucosa, and you would like to have the mucosa convex to try and simulate a natural root. This is very important. We are not talking only about the appearance of the crown, but of the overall tissue. The problem is that when you look at the area right after removal, extraction of the root, whether it was fractured or from any other reason, you stay with this type of socket that you see the gingiva around it. And the question is, what is the thickness of the labial plate, as you can see at this slice of the CBCT, that is around natural teeth at the smile zone? So as you can see at the CBCT, we are talking about very thin diameter of this labial bone plate. The dimensions of the buccal plate around natural teeth at the smile zone have been described in several studies, and here you can see part of them. And I will summarize it for you. The average thickness around a natural tooth is between 0.6 to 0.8 millimeters, less than 1 millimeter. Moreover, when you describe a tissue, a phenotype, and you talk about thin phenotype, you talk about less than 1 millimeter. When you talk about thick phenotype, is more than 1.5 millimeters. But 90% of the patients that we treat have thin phenotype. 90% of the patients have thin phenotype. And moreover, 80% of the incisor teeth have angulation buccally. And this is probably not only because of nature, but because of many orthodontic treatments that became very popular in the last decades. So with this in mind, you can understand that if you want to preserve this 0.5 millimeter in average of bone, it's a big problem. Why is it a problem? Because as you know, the root of the tooth is connected to the bone through the PDL, through the Sharpie fibers. The Sharpie fibers originate from the bone and are embedded at the cementum of the tooth. Once you remove the tooth, you remove the PDL, and you remove the PDL together with those Sharpie fibers that were embedded in the bone. Now remember, the bone thickness is about 0.5 millimeter. So once you remove this PDL and you tear the Sharpie fibers, you actually cause the very thin bone to resorb. That's why we call it bundle bone. Bundle bone because the bundles of the collagen fibers that are embedded in it, and the bundle bone is a tooth-dependent structure. No tooth, no bundle bone. No bundle bone, you will lose, in most cases, the labial plate unless you do something. Here we see what happens once you remove the tooth and do something. You let for spontaneous healing. The bone will resorb. And the more thin the buccal plate is, the larger the resorption that you will see of the bone and, of course, the tissue around it. That's why you will see more resorption wherever it was thinner before, let's say in the anterior teeth, at the buccal area, more resorption than on the palatal area where the bone is thicker. So this is how it looks like. The tooth number 12 or 7 was removed, no ridge preservation was treated there, and you see, obviously, the resorption of the whole site due to what I just described. And those of you who would like, you can read the nice article of Schropp and his colleagues from 2003, as you can see on the upper right side of the screen. So what do we do? In the majority of the cases where we start with very thin labial plate, we have to graft. We have to graft, and you can graft either with membrane and bone in the procedure that we all know, like GBR, or we graft with connective tissue. You can place the connective tissue simultaneously when you place the implant, or place the implant and augment with connective tissue at the time of uncovering if you bury the implant. If we do it at time of implant placement, we can use either subepithelial connective tissue graft or deepithelialized free gingival graft, or just cover it with free gingival graft at the so-called seal technique that was described by Kobe Landsberg many years ago. If we do it at the time of uncovering, we can decide not to graft if we have no defect at all and you start with very, very thick and convex tissue. Then you can go for punch technique. We never do it because we always try to keep and to utilize the tissue to our benefit. You can go for a roll flap. Again, we don't do it. We always go for connective tissue graft, whether it is a large or moderate defect. And then with the connective tissue graft, as you will see soon, we are able to create the convexity around the implant at the mucosal area, and as well to thicken the tissue to the minimum 3 millimeters overall buccal thickness as we want to get to have the tissue stable. So the two techniques to harvest connective tissue from the palate are either the deepithelialized free gingival graft, where you take a free gingival graft and then you deepithelialize it, or you go deeper with one incision and you harvest from the depth of the palate the subepithelial connective tissue graft. These are the two grafts, and obviously you can see that they don't look alike. The subepithelial connective tissue graft is more adipose, as it looks like, and more glandular, whereas the free gingival graft, after you remove the epithelium, is more condensed connective tissue. And we are using mainly this technique, as you will see. So let's start with the first clinical case. The diagnosis that we have to treat is an already existing implant at the left central incisor. The mucosa is thin, it is inflamed, the crown is not very aesthetic, the distal papilla is short. So the question is what to do. The patient is a dentist, and the implant was placed and restored by another team some years before. And actually, he wanted us to take care of it, maybe to remove the implant, augment, wait, and then place the implant not so deep and restore it. But in order to do it, you risk a lot, because to remove a well also integrated implant, and you can see there is no peri-implantitis here, the implant is covered by bone, will cause huge damage to the periphery. And we thought that we might treat this situation by leaving the implant where it is and just upgrade the software and change the hardware, the prosthetic hardware. And I would like to share with you how we did it. So first I had to cut the crown because it was cemented. I exposed the abutment. You can see that the abutment was manufactured not so precisely. It's not high level work of the technician. The implant is very deep, 10 millimeters under the tissue. And what I decided is to use the existing abutment to modify it as a provisional abutment, provisional for the duration of the provisional crown. This abutment has no finish line. It's a smooth abutment. I place it back with Teflon tape. I seal the orifice of the screw, and then I take acrylic shell that was prepared in advance. I reline it with fresh acrylic, and I decide where I want the margin to end. Because there was no finish line, then I can decide wherever I want. I place this retraction cord before I re-cement the provisional crown, not to let the cement go inside. And this is how it looks like 2 weeks later. So you can see that the tissue is less inflamed now. On the other hand, it receded a little bit because there is no inflammation, and the tissue has shrinked. But the condition of the tissue is much more healthy. And if we want to make any type of surgery, especially augmentation surgery, we need to operate in a healthy environment. We cannot do it when the tissue is contaminated and inflamed. So now when we have this provisional crown on top of the provisional abutment, we can go, and Mirela, my collaborator, is going to create the pouch and mobilize the tissue flaplessly with these microsurgical instruments. And this is a very delicate procedure because you need to be very cautious not to penetrate the tissue. And once she is able to mobilize the tissue on top of the implant and on top of the adjacent teeth and the papillae, then we know that there is enough space to insert the graft. And the graft is being harvested from the posterior part of the palate, as you can see here, very gently separated from the palate. And once it is outside, the epithelium is being scraped away, as you can see here. And when the very thin connective tissue is ready, we pull and push it into the created pouch on top of the implant and on top of the bases of the papillae, and secured with this type of sutures. Now let's jump 3 months forward, and you can see the nice convexity and thickness that we were able to get by this augmentation procedure. So actually we upgraded the software. Now the buccal tissue is in the thickness of more than 3 millimeters, as we already mentioned before, a very important factor. This is already the definitive crown, and the definitive crown have to be screw-retained. In very, very rare conditions, we cement crowns because we know that there is a direct link between implant perimucositis and periimplantitis to the cement of cemented crowns. And if you cement, then you have to choose different precautions, like the retraction cord that I showed you before for the provisional crown. So if I want to have a screw-retained crown, I need to have a channel for the screwdriver to access the screw. So this is the screw. This is the long axis of the implant. And as you can see here, if I use a regular screw and screwdriver, the opening will be buccally. And this is, of course, not acceptable in anterior implant restorations. So what we do in such situations in the last 5 or 6 years, we choose screw systems that are termed biaxial screw systems, where you can engage the screw head from the side from an angulation of up to 25 degrees. This enables you to use a screw-retained restoration, although the angulation of the implant is buccally located. So there are several implant companies that have their own biaxial screw systems, and if not, there are different companies like the Dynamic Abutment from Germany that create this type of screws and abutments or titanium bases to most implant systems. I place the implant, I screw it in, and what happens? I see blanching of the tissue, which means that the cervical portion of my crown is probably too wide. And if I leave it as is, the tissue will recede. After all the work that we did with the augmentation surgery, we don't want to lose even fraction of this tissue. When we talk about implant crowns, we use to separate the transmucosal component into two. We have the deep contour of the abutment or of the crown, which is this part that is close to the implant head, that is close to the bone. And then we have the part that is more close and facing the free mucosal or free gingival margin, the papilla, which is the superficial contour. It has been termed in the literature also as the critical and subcritical contours by the group of Ernesto Lee from the University of Pennsylvania some 10 years ago. I refer to it deep contour and superficial contour. So in this case, what I did is try to reduce the diameter of the superficial contour. Okay? Now the superficial contour is not so large, and I place it back, and there is no blanching, as you can see here, but still the tissue is suffering. You see the redness of the tissue, it's suffering, which indicates that the deep contour is also too big. So I have now to reduce the diameter of the deep contour. The deep contour here is actually zirconia on top of titanium base. So if I want to reduce it, I have to remove the zirconia, as you can see here, to expose the titanium at that deep part of the implant next to the crown, next to the implant head. And I try to achieve the slimmest, the narrowest stem possible of the abutment or of the implant crown next to the implant. This is a very important rule of thumb. Wherever you use any type of abutment or of a direct implant screwed to the implant head, try to get the narrowest part next to the implant so that you can create thicker band of connective tissue on top of the implant, on top of the bone, around the abutment. This is something that needs to be mastered in every implant restoration, whether it is anterior, posterior. I'm talking about, of course, bone-level implants, not tissue-level implants. Bone-level implants, whenever you restore, try to get the slimmest, the narrowest prosthetic components to allow for thicker band of tissue on top of it. Whatever implant system you use. And this deep contour actually allows for thicker tissue at the deep zone of the peri-implant envelope. So this is something that actually needs to be selected from the components of the implant system that you use. And if your implant company does not supply very narrow components, you need to ask them. But most of the prime implant companies today have this type of very narrow components at the base, at the stem of their abutments or titanium bases. Now, of course, if we start from a very narrow diameter and you want the crown to look like a natural tooth, you need to open up, to flare. And then there is the superficial zone of the peri-implant mucosa that is actually supported by the superficial contour of the crown. So the marginal mucosa or the free margin of the mucosa and the papilla are being guided and supported by the contour of your crown at the superficial part. And I will show you later on how we do it. There are many ways to do it. We use a specific concept and I will share it with you. So now we have actually upgraded both the software by the augmentation of the connective tissue and the hardware by letting the tissue have a very, very narrow deep contour and custom-made superficial contour. And look how the tissue responds from the initial time where we placed the crown before we changed the superficial contour, then we changed the deep contour, and you see how nicely the tissue adapted back to its original place after the surgery. When you look at the radiographs of the pre-op and 1 year post-surgery, you see that we actually deal now with narrower stem of the implant crown, even narrower than the abutment that was placed before. And you can see that the bone reacts very favorably. If we compare now the clinical image, 1 year post-surgery with the new crown and the pre-op, you can see that first of all, the tissue is not inflamed anymore and much more thick. Then if you compare even the papilla, before we had 6 degrees discrepancy between the distal papilla of the implant and the distal papilla of the neighboring central incisor, the natural central incisor. After 1 year, you see that this decreased to 2.5, which means that the papilla next to the implant is growing. And after 4 years, the 2 degrees decreased even more to 1 degree, which means that after 4 years, we still have growth of the connective tissue also at the papilla area. So this is something that we need to remember. Once you embed into the tissue some seeds from the palate, which is a different type of connective tissue, you can modify the phenotype that might have been very thin into a thick type of phenotype. Upgrade the software by this type of surgery. We want the software to perform as good as possible, and there are several prerequisites from the software, which means from the bone and the tissue, that we would like to get. The first is when you place an implant in healed sites, we would like to have immediate bone formation next to the implant, which means that we need to do something to cause the blood to transform into a callus and then into a soft bone and then to mineralize and become a young mineralized bone as soon and as fast as possible. Because the faster it happens, then you can load the implant with more security. On the other hand, when you place the implant into sockets in immediate implant placement, you want your implant to engage as strong as possible to the remnants of the bone apical to the socket. So you want to have an implant that the design enables for superior primary stability. You want an implant system that by itself, the different components, whether the implant head or the abutments and the prosthetic components, allow for maximum bend of soft tissue on top of it. And you want to have more bone around the implant head where it matters most, which is mainly at the 2 or 3 millimeters around circulating the implant head. And these are 4 requirements that we've tried to achieve by redesigning different type of implants already 15 years ago to improve the hardware and then to let the software perform better. So how did we improve or upgrade the hardware? I have to disclose now, for those of you who don't know yet, that I was in the team that developed the Novel Active for Novel Biocare 15 years ago, and then 7-8 years ago with the team that developed the V3 for MIS that was then part of the Dentsply Sirona group. And I have some commercial interest in those implants. I try now to explain to you why we tried to improve the regular circular implants that we used to have 15 years ago and some years as well. So a few years ago, we thought that we might have an implant configuration that is not circular at its head, which means that if we cut away some titanium from the head portion of the implant, obviously we will have more bone instead of this titanium. So we believe that if we will have less titanium at that part, the cortical crestal bone will not be compressed as we see in many implant systems that are circular. And we will not lose bone by trying to remove more bone to place a circular implant and not to compress the bone. We want to keep as much bone as we can and at the same time not compress the crestal bone. So together with Dr. Yuval Jacobi and Dr. Eric Van Duren, we created and actually developed this type of tri-oval or triangular implant head. And I will show it to you now how can we achieve these 4 prerequisites just by modifying the implant design. So the implant osteotomy relationship, which is very important, was created in a way that once you create the final osteotomy with the final drill and you place the implant, you have pre-designed chambers between the implant body and the implant threads and the bone for lots of blood clots. And we know that blood clot is the best material for future bone. So this is very important factor in every implant design to create as many blood clots in those chambers and to create the chambers in a way that will enable the biology to immediately start creating the different stages of bone formation. Then we wanted to have also a very good primary stability in extraction sites. So the implant bone contacts, especially at the apical part, were created to engage even minimal volume of bone and have very good primary stability. All the prosthetic components were designed in this tulip shape that you will see soon, that is very, very narrow as possible mechanically in the deep zone. And the connection itself is extremely precise and is a conical connection of 12 degrees which is, according to our experience, the best connection that we could find. Because as you know, conical connections can vary from 20-something degrees to 5 or 6 degrees. Each one of these different conuses have advantages but also disadvantages, and for us 12 degrees is the optimal type of conus for implant restoration. And the coronal shape of the implant was designed to be triangular, tri-oval, not circular, to eliminate the crestal bone compression that we see with circular implants, and then to have more bone. The natural question to ask is, if you cut away some titanium, how strong is your implant? And here is the tri-oval head of the narrowest implant in the system, which is 3.3 millimeters. And when we compare it to the data of different implant companies like Nobel Biocare, like Biomed 3i or Straumann, and we compare it to their data when they compare the endurance limit or the fatigue strength of their narrow implants around 3 millimeters or 3.5 millimeters compared to other implants, we can see that we are talking more or less at the magnitude of between 120 to 260 newtons. So these are the magnitudes of narrow implants of some of the prime implant companies. The V3 endurance limit is much higher, is around 370 newtons, although, or especially because it has this specific design of a triangular or tri-oval head. So the implant is not weaker, for sure. This is the narrowest implant, and you have different implants that are much wider than the 3.3 up to 5 millimeters diameter. So once we understand that, let's go to a very simple clinical case. We see that the molar site is already healed, as you can see here, and I will now design and plan where I want to place the implant. And we do it with software, the MSoft. Here I will place the implant to allow me to have the optimal place in the bone, at the same time have its screw retained with the future crown. So we reflect a small flap, we place the surgical guide, we drill through the guide. Sometimes we also place the implant through the guide, but in these cases there is no need. So after I drilled the osteotomy, I place the implant, as you can see here. So the osteotomy, this is the final drill osteotomy, is circular. The implant that we are going to place as a triangular head, you can see that there are 3 areas of this head that engage the bone. Okay? And you can see also that there are some gaps between the smaller parts of the triangle, the little flat or little convex parts of this triangle, and the bone that are filled up with blood, and this blood will turn to be bone. So you do not lose the cortical engagement with this type of implant, because if you have a narrow head or a back-tapered head, the head will not engage the surrounding bone. Here you do engage the bone in those 3 areas, and at the same time you do not compress the bone, because the bone in between those 3 pillars that engage it can collapse a little bit, although it's a cortical bone, although it's a crestal bone that is pretty tough, still has some elasticity to allow for collapsing and prevent any type of compression on the bone. So this is actually the size of a circular implant that you should head to place if you wanted to get at the end this type of bone around it. Much smaller and weaker implant. So the nice thing is that you actually get the size and the volume of bone around this triangular implant as if you placed much smaller implant. So instead of place a 3.3 circular implant, you can place a 4.3 triangular head implant and get the same amount of bone, which is very nice, I think. We place the implant infracrestal. As you can understand, this implant system allows you to place it infracrestally because the implant has been designed like that. And this is how it looks like after 6 weeks, which allows you to take the impression or scan it. And then Yuli Cooperstein was the technician here, created this molar crown, screw tank, and this is how it looks like after 1 year. So you can see that the tissue adapts very well, and the bone is covering the implant crown interface. At 7 years, the bone is still there. Not only the bone does not resorb, but it maintains its same level, stem stability over 7 years, and the tissue matures and fills up the papillae between the implant crown and the adjacent natural teeth crowns. You can see where the implant head is with these dotted lines, and the bone is eventually on top of it. This is not an episode. This is what we see in the majority of those type of implants. Another case, you can see how the bone refers to the implant head right after crown placement. And then 5 years down the road, the bone covers. The bone actually matures, condenses, and grows on top of the implant head. So you don't see here what we used to see in regular circular implants, some bone resorption during remodeling. Here you see either stability of the bone during the remodeling or even some bone growth on top of it. Another case, also a molar case, within 3 years, from 2017 to 2020, you see how the bone is growing and covering the implant abutment interface. Another case, we lost bone when we placed the implant in 2016. You can see it on the left-hand side of the screen with the healing abutment. And then we placed the crown. Again, look at the slim part of the deep contour of the crown, 2016. And 3 years later, you see some coronal marginal growth of the bone. Another case, within 5 years, look at the mesial and distal aspect of this implant crown. The bone is growing. And I can show you many radiographs like that. Actually, the majority of the results with this type of triangular head implant are like that. You place the implant either equicrestally or infracrestally, depending on the thickness of the tissue that you start with. And then you see stability of the bone, and in many cases, bone growth, whether it is anterior, posterior, upper, lower, single, multiple implants in every indication. Also, in lateral window size augmentation like here, although we have a triangular head, the 3 areas that engage the bone are enough to engage the implant just by the coronal portion of the implant. And here again, 5 years post-op, look where are the implant heads and where is the bone. The bone is covering it, and we have very nice bone response. So a very interesting article was published last year by Yin and Brunsky and their colleagues, where they compared the mechanical and biological advantages of a tri-oval implant design. Tri-oval is triangular that has no very, very sharp edges like the implant that I showed you before. So what they found out that the primary stability of this type of tri-oval implants is not changed when you place the implant. So you have a very good primary stability without increasing the insertion torque. This is very important, which means that you do not compress the crestal bone. The areas between those three pillars presented very low compressive strain, and also they checked how the osteocytes are behaving and reacting to this type of implant design, and they saw less osteocyte apoptosis, death of cells that create bone, less death of cells around the tri-oval implants, which means that you will have minimal bone resorption when you compare it to circular round implants. And this is something that we see clinically in every case. Not only that, but the rate of new bone formation was also faster around the tri-oval implants. And in contrast to the circular normal round implants that exhibited a significant dip in stability, and you all know that in implant surgery, we expect a decrease of stability of the implant between the first and third week, because the bone remodels, and we know that the bone adjacent to the implant usually resorbs until new bone is formed. It takes time, so you have this dip. In the tri-oval implants, they could not find this dip. They maintained their stability throughout all the osseointegration period. So at the end, the bottom line was that collectively, the different biomechanical analysis that they went through in these studies demonstrated superior in vivo performance of tri-oval implant design. And they did it in mouse models. We know it from our experience of thousands of colleagues that use it all over the world for the last 6-7 years. Let's have a look now on the anterior zone, the smile zone, how this type of concepts actually are implemented. Here we see a patient that number 11 or 8 is non-resorbable. It broke deep into the root. It started already, as you can see at the clinical picture, with some periodontal problem, no distal papilla, and recession of the gingiva. And we removed it. We performed some ridge preservation, and this is how it looks at 6 months. And once we were about to plan the implant position and perform it, she broke the other side lateral incisor very deep. So actually now we have two sites. One is a healed site, periodontally involved, and a fresh site where we will remove the very deep broken root of the lateral, and we will place two implants, one at the central incisor and the other one at the lateral incisor. So we removed the lateral incisor, we placed these two implants, as you can see here, and we covered it with GBR. I will not go now through the surgery. Let's jump 6 months down the road. We expose the implants and we place some free gingival graft deepitalized. As you saw before, you already know, we do it flaplessly. And then we make an impression, a scan, and our technician, Yuli Cooperstein, is performing within 24 hours this type of composite milled CAD-CAM crowns to connect to the implants and to place on the adjacent teeth. Now, the cervical portion of these crowns is far away from the tissue. We do not want to compress it, where we just augmented it with the connective tissue graft, and we want to let it heal. And we know that right after the surgery, we might get some inflammation, and the tissue will be a little bit thicker until it shrinks back. We don't want to compress it. So actually, the superficial contour of the provisional crowns, it is much narrower than it should be. And this is how it looks like after 1 week. After 1 week, the papilla of the central incisor implant crown are not matured yet. Around the lateral incisor, it looks much better. But we know that we wait. And after 2 months, the tissue starts to heal. It is not matured yet, but it's healing definitely. And now we can take the impression and proceed to the definitive restorations. Now I want to share with you how we actually tackle the superficial contour of our implant crowns. And this has been published many years ago in 1994 by myself and Kobe Landsberg, and we termed it the cervical contouring concept. Actually, it's a model-based design. What do? We take an impression or we scan, it's not important, and we have now the model with the alveolar part, which means that we have all the tissue around the abutments and the implants in the model. At the same time, we never start any restorative treatment where we change the shape of teeth without having a diagnostic wax-up. A diagnostic wax-up is actually the target where we want to get at the end of the treatment. This is the optimal shape of the new restorations, but also the optimal shape of the tissue around those restorations. So what we do is actually mark the free gingival margin on the diagnostic wax-up. And here you have the QR code, those of you who want to take a picture of it and read the article later on. And we transfer the markings from the ideal model, of the wax-up through a silicon index. If we do it analogically, if we don't do it analogically, we do it on the screen, to the actual working model. Now the working model have these markings that represent the ideal shape of the tissue that we would like to get. And we have now to match the actual shape of the plaster to these red markings. And we do it very, very simply by using knives and rotatory instruments. We do it only on the superficial zone. We don't go deep. Once we have created on the model, we redesign, we reshape the peri-implant envelope at the superficial zone, then the technician can go on and build the crowns according to this new design of the envelope. And here we have the crowns of the natural teeth as well as the crowns on top of the implants. The implant crowns are actually made of zirconia based on titanium and layering of lithium disilicate that was bonded to the zirconia after the zirconia was fired with very thin layer of porcelain to be able to etch it, to bond these two materials, the lithium disilicate, the IMAX, and the zirconia. So you can see here that we start from a very narrow deep zone, which is the titanium base, And then we have the zirconia, and only at the superficial zone or the superficial contour, we have the IMAX, which is much more aesthetic than the zirconia. This is how it looks like when it is on the model. So you see that although the implants were placed pretty palatally, and we have this way to go with the design of the superficial zone, when they emerge from the tissue, they emerge flat or at 6 degrees like a natural tooth. And this is the beautiful work of Stefano Inglese from Italy. And you can see how the tissue is now responding throughout the years. This is 1 week after we placed the definitive restorations. This is after 1 year. You can see how nicely the papilla start to fill up the spaces and they become more sharp. And this is after 4 years. Actually, after 4 years, in my eyes, it looks less nice than after 1 year. Why? Because two things happened throughout those 4 years. The first event that happened is that the natural teeth continue to erupt, whereas the implants stay in place. So relatively to the teeth, the implants are infra-positioned, submerged. Look at the incisor line of the two lateral incisors. They were at the same line, now number 7 or 12 erupted, whereas the implant on number 10 stay in place. Look at the incisor lines of the two central incisors. The left crown is on a natural tooth that erupted, whereas the right central incisor is on an implant that stayed submerged. So this is something that we know that might happen at any age, not only during puberty, but also at the age of 30, 40, 50, 60. We cannot predict it. It might happen to everybody. And sometimes it creates lots of aesthetic problems. The other thing that happens is a continuous growth of the connective tissue that was harvested from the palate. This is not a problem actually, because if you want to remove the extra tissue, you can do it easily with different instruments. But again, this is something that we know that might happen, especially when you harvest it from the posterior part of the palate or from the tuberosity. When we look 4 years down the road, the implant crowns emerge very nice from the tissue clinically. And when we look at the CBCT slices, we see that we were able to create more than 3 millimeter overall of connective tissue and bone in both sides of the central incisor and lateral incisor crowns. Again, the periapicals, the bone around those implants is stable, and the patient is happy. Now, this is not enough. We thought that we might increase the tissue stability by adding another prosthetic component that will enable us to avoid some problems that we see with regular prosthetic components in implant restorations. What we know is that once you screw in an abutment or a crown directly to the implant head, through the channel, through the chimney of the screw, contaminants get in. You cannot hermetically seal it, whatever material you use. And if the abutment is, the connection is not very, very precise, like happens in most implant systems, then this contamination will go through the chimney, through the base part of the abutment and the implant head, and then continue to the periphery, to the interface of the implant abutment, and the contaminated zone cannot be tolerated by bone. The bone will resorb. This is, by the way, one of the theories why platform shift helps the bone to stay more stable, because this contaminated zone is being pushed from the periphery inwards, and then the bone can stay on more coronal position. So this is a problem. Whenever you use any type of two-piece abutment and screw that goes through it, this might happen. And you can have here different articles that describe this phenomenon. The other problem is that if you place and remove many times the prosthetic components from the implant, you might also trigger some tissue recession and bone resorption. And three groups of our Italian friends, Luigi Canullo, Marco De Gidi, and Grandi, proved it in their studies. So one of the reasons that the tissue level implant is more biologically oriented is that the interface of the prosthetic platform is far away from the bone. It's at the tissue level. And then these repeated insertions and removals of prosthetic components do not harm the bone. We came out with an idea. Let's place a one-time abutment. We place the abutment. The abutment is designed already to be very slim, so the deep zone of the prosthetic component is already performed by this abutment as slim, as narrow as possible. Place the abutment and don't remove it anymore, like we do with multi-unit abutments. And this abutment can be used either for multiple crowns or for single crowns. Actually, once you place this abutment, you transform a bone-level implant into a tissue-level implant. But you can still use all the advantages of bone-level implants because you can augment on top of it, you can bury it. On the other hand, once you connect this abutment, the prosthetic platform is far away from the implant and from the bone. So you can place and remove as many times as you can. It doesn't hurt the patient. You don't need to anesthetize it. You don't disrupt the epithelial attachment from the abutment every time you do it, like you do with any other abutment system. So you have the good or the advantages of both worlds. Not only that, but we decided to eliminate the chimney. So it is not a two-piece component where the screw goes through the abutment. The screw is integral part of the abutment. It's a monoblock. There is no chimney. So no contaminants to go through it. The abutment has internal connection and then a flat connection, as you can see, but it is far away from the bone, far away from the implant head. You can have either an engaged connection for single crowns or non-engaged, free rotation for multiple crowns. And the design is the slimmest possible mechanically. So you cannot get a slimmest design. You know that actually once you connect it, the deep zone of your prosthetic component that is created by this connect abutment is the best for the tissue around it. We have in the market some ideas that are more or less the same, but the other type of this type of abutments are not monoblocks, are two pieces. What does it mean? You have a chimney and you have a screw that needs to go through the abutment to secure it. So this screw is eventually large, and when the screw is large, the abutment needs to be larger because otherwise it will break. So you cannot get to the slimmest design like we have in a monoblock. Moreover, I already mentioned before the 12 degrees in our experience is the ideal degrees for conical connection. When you have a larger conus, like in this abutment, which is 20 something, 22 degrees, you cannot seal very well, as you can see on the V3 connection. You can see the gap that is not seen once you torque down the connect one piece to the implant. And of course, if you still have a chimney for the screw, then this is the path for contaminants to get inside the abutment and then go outside to the implant abutment interface. So in my opinion, there is no doubt that a monoblock transmucosal component, like you see here, is much better biologically when you have the right connection, so that you torque it down to 30, 35 Newton centimeters. It will never reopen, whether it is in the molar area or central incisor, single crowns, and of course it cannot open if you have connected crowns on top of it. Like, I would like to share with you now several cases, and now you already have an augmented protocol algorithm that is composed of several steps that you know that might give you better chances for long-term stability. You already heard, you create the thickness of the tissue, you use implants that enable you to keep the crestal bone and even let it grow. You have now a component that is a one-time abutment that you do not remove, and not only that, it is slim, it allows for very thick band of tissue around it, and is monoblock, so no pass of contaminants inside. So here I placed the two implants infracrestally, then I connected these connects. Here I decided to place them very close to the tissue level. We will have two connected crowns here on top of the connect abutments, and a single crown on the molar and the premolar. Here you can see after I screwed them on top of the connect abutments, and you can see that after 3 years, the bone is on top of the implant head. This is a one-time abutment. We place it, we don't remove it. We take the impression on the prosthetic platform of the abutment, not of the implant. And not only that, if you want to use any type of healing abutment, you use these abutments as healing abutments. They have also cover screws in different height that you can choose. So this is a very nice concept. Let's proceed to the two last clinical cases where we try to integrate all the insight that I shared with you up to now. So here we have a very nice patient. It's a part of full mouth rehab. It's an interdisciplinary treatment with ortho and some other disciplines, but let's concentrate on tooth number 9 or 21. You see that the root is splitted already. There is a huge bone defect there. The CBCT shows you that there is no bone labial or palatal to the root, as you can see here. But when you look at the clinical picture, there is very slight gingival recession around it. So there is no bone, but the tissue is still there. This is according to the classification of Elian and Tarnow and Cho, probably type 2 defect, where you still have the tissue, but the bone is resorbed. Whereas when you have both tissue recession and bone resorption, is type 3. Type 1 is when you have both the labial plate and the tissue as originally nature created. So here we have type 2 or type 3. It's not so important. What is important is that can we remove the root and place an immediate implant? And this is very interesting because it depends on the concept of the, I would say, implant sect that you believe in. For instance, the group of ITI published 4 years ago their very nicely written article, and they try to answer when can we place an implant immediately, when should we place it early or late. And when it comes to immediate implant placement, they set up some requirements. They set up that first requirement of immediate implant placement, because it is a complex procedure, should be performed only by experienced master clinicians. This is the first thing, which means that if you are not experienced at that particular procedure, and master clinician for me is somebody that has at least 10 years of experience at that specific procedure, don't do immediate placement. Moreover, only when ideal anatomic conditions are present, which means fully intact facial bone wall, okay, so all the periodontally involved teeth are not candidates for immediate implant placement. And when you have a thick wall phenotype of more than 1 millimeter, as you remember, it's about less than 10% of the population. So you need to have non-periodontally involved tooth, thick bone phenotype. You should be a master clinician. You need to have thick gingival biotype, no infection at the extracted side, and enough bone apical to engage the implant at the apical part. So these are very, very strict requirements, which actually excludes the majority of the clinical cases that we treat from immediate placement. And the question is that so? Because as you remember, for more than 15 years with the Nobel Active, we have been placing immediate implants, and sometimes we even restore them immediately. And now with the new designs of implants, we know that we do it. I believe that the reason for their conclusion is because the hardware that this group of people were using was not designed for immediate implant placement. And if you use this type of parallel sided implants or this type of threads or this type of heads, obviously it is very difficult to get immediate primary stability high enough to be able to place the implant. But in the last years, the last 15 years, the implant designs of different systems allow you to place implants immediately, whether they are conical and very aggressive thread design like the Nobel Active or some other implants that counterfeited, or the smart design that I already explained to you of the V3. So here we come back to our case, clinical case. I plan with the software where I want to place the implant, and I will have the surgical guide that will allow me to drill exactly where I want to place the implant. I will place the implant, and then the missing bone will be hopefully reformed throughout a GBR procedure. So I already removed the broken root, raised a small flap. Here I finish my osteotomy right where I planned it, and here I place freehand the V3 implant. I can place it through the guide, but no need. I have excellent primary stability, although I am not going to load it now because we want to build up the missing tissue around it. So even in such situations, the primary stability that you get is usually around 40 to 60 Newton centimeter. Then Mirella is replacing me at the chair, and she is performing the GBR with a triple membrane palatal membrane and two buccal ones. The inner part of the membrane are O6 plus, highly cross-linked collagen membranes. And the outer part, I think it was here a BioGuide, which is more easily manipulated. You can use these tags. We also place autologous bone and some xenograft, some PRF that helps us to get nicer immediate healing. That's why we use the PRF. And the whole procedure has been closed with primary intention sutures. You can see here that I used, instead of cover screw, a very narrow healing abutment to help me maintain the augmented site in place. After 6 months, we raised the small flap because we wanted to see if we have there something that looks like bone. So we raised the flap, and this new tissue bleeds like bone, feels like bone, so probably it's bone, although we did not take any biopsy. We removed the healing abutment. We connected the connect. We could have placed connect earlier, but at the time of implant placement, we didn't have the connect yet. It was some years ago. So we placed the connect with the cover screw, and Mirella added some connective tissue grafts. So here it's an upgrade of the software, first with GBR, and then with connective tissue graft, and with an upgraded hardware by the implant itself and the transmucosal one-time abutment. We screw to it the provisional crown. This is how it looks like after 1 month. The tissue is not matured yet. It takes years, 2 years probably or more, for the tissue around implant restoration to completely mature. But there is a nice initial healing that you can see here. And you can see that the prosthetic platform is actually 4 millimeters more apical than the labial free gingival margin, but we know that the free gingival margin will further recede a little bit. So it will be at the end about 3 millimeters apical to the free gingival margin, and 2-3 millimeters away from the implant head and the bone. So here, again, we take an impression. We decide whether to go analog or digital according to the lab technician that we collaborate with, that is our partner in this treatment. So Stefano is still analog. There are other technicians that we collaborate that are more digital. It's not so important for us. We can take either an elastomeric impression, as you can see here, or a digital scan, as you will see in the last case. Here you can see the nice restorations of the adjacent teeth and the peri-implant envelope modification according to the cervical contouring concept. Now, the deep contour is already been set by the transmucosal connect abutment. So here we just need to recontour the superficial zone. Then we bond adhesively all the restorations on the natural teeth, and this has been done with selective rubber dam application on each and every tooth. This is how adhesive bonding should be done. Otherwise, you don't do a true adhesive, because you cannot control perfectly the surface of the tooth while bonding. So this is how it should be done, and I believe that most meticulous dentists worldwide do it like that. And here is the definitive crown. The definitive implant crown here has an internal titanium base, a zirconia core around it, and here again we decided to use IMAX veneer.
Just a sec.
My Siri somehow responded. I don't know why. Anyway, we decided to have an IMAX veneer on top of the zirconia because the adjacent restoration on the natural dentition were also made from IMAX. And we would like to harmonize the material that is being placed on the natural dentition and on the implant crown. So actually, this crown, again, is being constructed from two different materials bonded together. And here I use this type of biaxial screw, as you can see here. So you can see the picture on the left-hand side of the screen, the relationship of the triangular implant head, the transmucosal one-piece abutment, and the crown that is being screwed to the prosthetic platform, far away from the bone, far away from the implant head. And then you can see on the clinical pictures before I screw it and after it is being in place. This is the 2 years. So at 2 years, you see that we went through also additional treatments, the other sites, orthodontics and some other treatments, but you can see how nicely the tissue get the convexity around the implant crown from the occlusal aspect. And this is at 3 years. Actually, at 3 years, you see that we need now to narrow the cervical part of the implant crown to let the papilla grow even more, because now it is squeezed. The patient doesn't live in our country, so we wait now for the corona time to COVID-19 to disappear, to let him come to our office, and then we will easily screw out the implant crown from the connect abutment, and we will narrow the distal part of the crown to allow for the mucosa and the papilla side for the connective tissue to further grow and fill the space. When we look at the radiograph, again, at 3 years, the bone is covering the implant abutment interface as expected, nothing special. Okay, let's move now to the last clinical case. Here we talk about two anterior teeth, two central incisors. Both of them are hopeless periodontically. One of them is even with a broken root. The crowns are anesthetic, as you can see. You can look at the CT slices, CBCT slices, and periapicals. We start with recession of the tissue, with resorption of the bone. This is definitely a type 3 case. And the question is, how are we going to stage the treatment? Are we going to remove the teeth to augment the socket, not only preserve, but augment it, and then place implants in a late or delayed placement? Or maybe we can remove the teeth and place immediate implants, or maybe even remove the teeth, place immediate implants, and even immediate provisional crowns. So this case has been also described at the Compendium of Continuing Education. Those of you who would like to read it in detail, here you have the details. You can take a picture of the QR code and you will get the PDF of the article that we published together with Mirella Ferraru. This is part of the planning that I do. So I decide to place both implants to allow me to connect to them the transmucosal component, the connect, and on top of it, the provisional crowns, if I get immediate stability higher than 35 Newton centimeter. But usually with this type of implants, because of the design of the apical part and the relationship with the osteotomy, you get higher immediate stability. And when we talk about adjacent immediate implant restorations, I advise all of you to go back some years to 2003 and 2004, where Tidou Mankou, our friend from Windsor, England, has published two beautiful articles in PPAD, one of the best clinical journals of that times. So this is the actual design long implants because I would like to get as much apical bone as I can. So these are 16 millimeters length implants. Then I have on top of them the connect screw, and immediately on top of the connect, the prosthetic platform is planned to be about 3 millimeters apical to the free gingival margin. We will screw the provisional crown. So I remove very gently, flaplessly, the teeth. There is no something like atraumatic extraction. Every extraction in trauma is for the tissue, but it's less traumatized. And then flaplessly here, I place the surgical guide and I drill through it. Then I decide whether I want to place my implant through the guide or I can remove the guide and place them freehand. And in this case, I decided to do it freehand, right into the osteotomy that is expecting to receive the first implant. And we have on the implant driver these two slots that mark 3 and 6 millimeters, so you can know how deep you are relative to the free gingival margin. And here, when the implants are in place, as you can see, I will take the connect abutments and screw them to the implant heads. I can torque them to 30 Newton centimeters because the implants were torqued to 50 Newton centimeters. Here you can see the connects in place, about 3 millimeters as was planned. And once the implant and the connects are there, I have these titanium sleeves that allow me now to get and reline the acrylic shells and have screw-retained restorations. And Mirella, while I am finishing and polishing the provisional restorations, is taking my place and harvest the connective tissue, deepithelize it, and then, as you can see here, she mobilizes the tissue. We already saw how she does it beautifully on top of the implants and the papillae. Then she condenses some autogenous bone from the osteotomy and some xenograft, and on top of it she places the connective tissue, and we connect the provisional crowns, and we have this cross suture to pull a little bit the tissue where originally it was receded. So this is how the patient leaves the office with 2 immediately placed implants and 2 connected provisional crowns. This is at 4 months. Usually when we do it, we open the bite because we don't want any contact of the antagonist teeth with the freshly placed crowns on top of the implants. So we use some provisional composite stops on the lower premolars and lower molars for the duration of the first 3 months. Then we remove it. And we ask the patient for the first months not to eat anything hard, anything, not anteriorly, not posteriorly, soft diet for 1 month. So this is something that we believe can help the immediate healing around these immediately placed implants. And at 4 months, we can continue, although the tissue is not matured, but it's enough for us to know that we can continue to impression making. So we can either digitally scan the prosthetic platform of the connects with this type of scan posts, or we can take a regular elastomeric impression with an open tray, depending again on the technician that you collaborate with. Here we collaborated with a technician that is both digital and analog, so we prefer to send him both data. On the analog model, he uses the diagnostic wax-up shapes in order to mark the tissue, the free gingiva throughout the process of the cervical contouring, and then he will remove some plaster from the superficial zone to allow for the optimal configuration that will be filled by the definitive crowns. And the same goes at the digital design, because here again, he will remove whatever is needed according to the cervical profile of the wax up, and then he will design the zirconia bases according to this new contour of the tissue. And these are the zirconia bases, the zirconia frames. Here we don't use any Emax or any other restorations on the adjacent teeth, so he decided to go directly and firing the zirconia with ceramics. No need to go for lithium disilicate. Beautiful work by Giuseppe Romeo from Torino, Italy. Here are the definitive zirconia layered crowns that are being now cemented or glued to the titanium sleeves. And here are the two connected crowns that we are going to insert on top of the connector abutments. If I would go directly with my crowns to the implant connection, most probably I would go with two separate individual crowns. But because the type of connection here is not conical and is actually a flat connection, I prefer, if I have the possibility, to connect those crowns and to try to even the forces of mastication on two implants rather than each one individually. This is why they are connected here. You can see that one connection is non-engaged, the other one is engaged. Whenever you have multiple implants, then all of them need to be non-engaged. You can choose only one to be engaged, otherwise you will not have passive fit. This is basic geometry. You can see also that the cervical profile of each crown is different. On the right-hand side, the crown on the right-hand side, we have a convex profile, because I would like to support the tissue, even push it a little bit apically. On the other side, you will have a concave shape of the cervical portion of the crown, because this is where originally the tissue was much more apical and we augmented more. If you noticed, I also placed the implant on number 21 or number 9, more palatally, to be able to have more thickness of tissue at that area that I wanted to augment coronally. So here are the two different configuration of the connected crowns, and this is when we place them intraorally. You can see how nicely the tissue adapts around it, and this is some weeks after, 2 weeks after connection of the implant crowns. And down the road, 2 years, again, what you see is that the tissue keeps on growing, and at a certain moment, if this will be a problem for our patient, we can always cut it. It will keep on, continue growing. It never stops, most probably, until it gets to a certain thickness. But as long as it doesn't disturb our patient, we are fine with that. Again, you can see how we started, where was the tissue before we removed those teeth, then after 2 weeks, and then after 2 years. So radiographically, again, the bone is on top of the implant heads. And when you look at the CBCT slices, we were able to achieve some new thickness of bone and soft tissue buccal to the implant head in the magnitude of 3 millimeters or more. So to summarize, what is the algorithm that I would highly recommend each one of you if you would like to get stability around your implant restorations. And this is something that is right for now. I know that in 1 or 2 years, some things might be modified or replaced. But this is what I can share with you, the best thing to do today. And here you have, again, many V's for the tissue envelope, for the implant, and for the prosthetic concepts. The more V's you can have in each and every implant treatment that you do with any implant system, the chances to get healthy bone and healthy mucosa around it and a natural looking aesthetic restoration are higher. The first V, as you remember, you need to create a combined thickness of bone and mucosa buccal to the implant head of more than 3 millimeters. The other step, the crestal thickness of the mucosa alone needs to be more than 3 millimeters, and if it is not more than 3 millimeters, place your implant infracrestally, place an implant system that allows you to place it infracrestally or augment it surgically. I highly recommend, even if you're very, very, very experienced, to use 3D planning. This always helps you. You never regret for the time that you invest during the planning, because this reduces dramatically the surgical time. And in most cases, most circumstances, place an implant infracrestally. Use only high quality implants. Today you have outstanding, high quality implants that are not as expensive as we used to have some years ago. And I believe that post COVID-19, even the expensive implant systems will be much more affordable, because this just makes sense. We don't need to pay for different expenses of the high status of the implant companies that are for different type of salespeople, sales force, or whatever they used to spend. I don't need to see the representative of the implant company once a month. It's okay. I want to have high quality implants in affordable prices, and this is something that you can get today all over the world. Use implants that have reduced heads, whatever is the configuration, but don't use implants that have a larger head than the body, a flaring head. It doesn't make any sense. You compress the crestal bone, you are going to lose this bone and have some implant threads, and this is the beginning of a catastrophe. So why to use such implants that don't make any sense? One-time abutment, if you can use it through different types of multi-units or whatever abutment that you have, try to avoid repetition of placing and removal of the prosthetic components. No cemented restorations. If you have to cement a restoration, use precautions like retraction code, but try not to cement restorations and plan your implant placement to allow you for screw-it-end restorations. This is imperative in modern implantology. By the way, if you do place a retraction cord, place two halves, one half buccally, one half palatally. It's much easier to remove it later, and this is a great tip from our beloved friend from Spain, Iñaki Gamborena. The deep contour of your abutment or your implant crown next to the bone, next to the implant head, should be always as slim, as narrow as possible. This is a rule, whatever implant system that you use. The superficial contour you can design as you like. You can do it chairside, you can do it trial and error. There are many ways. I shared with you one way that we do it. This is the cervical contouring concept that in our hands works beautifully. Of course, after you have enough tissue that you can manipulate on the model. So usually it's either if you had already a thick phenotype or you augmented it with connective tissue. With that, I would like to thank you very much. Before I move and I leave my full screen, here are some ways to contact me. Those of you who would like, whether through email, Instagram, or Facebook. And Joseph, let's come back now.
Dr. Bichacho, beautiful work, beautiful results, coming from a very intelligent mind. Thank you. We enjoyed it immensely. I'm waiting for a few questions. If anyone have anything, just start posting it, please, for us. I loved how you explained with the abutments how thinner and thinner we're going about the cervical part of the abutment. I remember a long time ago when we used to think a more convex abutment or the cervical part of abutment will give us a better emergence profile. And then we started doing it concave just to have a better or more volume of the tissues. Now we're getting as thin as we can.
Yeah.
And the only thing that are holding us from getting or using smaller and smaller implants is the jumping distance with the bone. And with the V3, you did it beautifully because we can get the benefits of both worlds, like smaller implants while having the 3 chambers for the jumping distance to be less challenging. And we're able to achieve this bone.
Actually, the implant is not smaller. The diameter is a normal diameter. Just because of the trioval head, you are far away from the bone. So you don't sacrifice the implant strength. On the contrary, this is very important because, as you say, you can go with very small diameter implants, but then you sacrifice the strengths, and in certain areas you don't want to.
Yeah. And the 6 little corners between in every space between the bone, it helps with the vascularity and the bone to grow a little bit faster.
Yes, definitely.
With the implants that are a little bit having more convergence, like on the top, would you do something about the transition zone to avoid more of the soft tissue filling in rather than the hard tissue, or it doesn't matter anymore?
No, it doesn't matter. It doesn't matter, and it depends on the situation. If you have a marble bone that hardly bleeds, then you better fill up the gap or the jumping gap with some biomaterial that will prevent the epithelium downgrow, and we let at the end some bone grow into it. And what we do in this situation, we fill it up usually with autogenous bone that we collect from the osteotomy, and we place some blood that we take from the surgical site on top of it. But this is only in those cases that the bone doesn't bleed or hardly bleeds. Otherwise, if you see that it fills up with blood, the blood will start to clot within hours. Much faster than the epithelium will start to downgrow. And if you close it and support it, either with the tissue, if it is a 2-stage, you bury the implant, or if you have a healing abutment and you close it very well and adapt it, then there is no fear of epithelium downgrowth. So the only advantage of having this type of triangular head is that you don't lose cortical stability, because when you have back-tapered heads, you don't have cortical stability. You rely only on the stability of the spongious bone, and sometimes you go to the artery cortex, but very rare. And this is something that is disadvantages. I would like to have, if I can, very nice stability for my implants, also from the crestal bone.
And a very good rubber band of connective tissue around.
Right.
The
That's right.
I was always wondering if, what's your thoughts if the titanium alloy in itself was a little bit more malleable for the abutment and the implant when they're being connected? will this decrease the pumping effect of all the acid coming out of the edges of it if the alloy in itself is
Well,
more?
actually, this is the case in many implant systems because most of the abutments are made from stiffer titanium alloy, what is grade LE23 or grade 5 alloy, which is hard. And some implant systems are being made from softer titanium like grade 4 or even grade 2.
Yes.
Ankylos, for instance, is grade 2. Some implant systems are grade 4. And there are some believers that still believe that if you go with this type of titanium, you are more biologically oriented, although there are no scientific evidence that medical grade 5 or LE23 causes any harm by itself because of the aluminum and the vanadium that strengthen it. So I think that the majority of implants in the world today are made from this grade 5. Now, if you have two stiffnesses, one is softer than the other, and you torque it down, you create what is called cold welding. But what is more important is the adaptation and the preciseness of the female part of the implant head and the male part of the abutment. The more precise you can get, and this is up to the implant manufacturer, then you don't need more than that. What is the problem? The problem is that in order to get these low tolerances, as we call it, you need to replace the knives of the CNC machines much more often. You need to calibrate them more often. You need to invest more time. This takes, this costs more money. So implant companies that are trying to cut their costs don't pay attention to this. But for us as dentists, this is of primary importance. And unfortunately, you have some implants in the market from very prestigious names that the connections are awful. And moreover, many dentists try to save some money, and instead of buying the original prosthetic components that are used by the implant company, go for some other components where the preciseness usually is even lower. So you, as a dentist, need to think what are the weak points of the system that you use and try to strengthen them, and not add some weaker points to whatever is not completely, I would say, ideal. This is why I highly recommend use implant systems that have very, very tight connections, very low tolerances in manufacturing, and use original components. The money that you pay for it will save you lots of trouble and headaches, and especially your patients in the future.
Dr. Bichacho, with all your enormous experience and decades in all the literature and everything, when you lay backward and think what is the next 5-10 years are going to be seeing in the implant world and implant designs, what's your thoughts? What's your imagination like?
Well, I can just hope. I can hope that the implant systems will not create any compression on the cortical bone, which means that I think that every implant system needs not to be circular at the head of the implant. It doesn't make any sense. It is some concepts that come from different industries like carpentry, or when you want to place a screw in the wall, but we are talking about living tissues. This is not a brick wall. This is not wood. And this is something that every implant company needs to be able to understand biologically. You cannot compress it, and you don't want to lose the bone around it. So it just makes sense for me that the heads of the implants will not continue to be circular, and implant companies will need to adjust to it. The other thing, I believe that we will have more and more implant designs that will enable faster bone osteogenesis around it in terms of the surface and in terms of the configuration design and the threads design, and get very good primary stability. We already see some implant systems in the market in the last 5 years coming like that. And I believe that we will have some implant coatings, or at least at the coronal part of the implant and at the prosthetic components, that will be kind of antibacterial. That will be antibacterial, that will not allow plaque to accumulate and create the peri-implant mucositis. Now, there are two ways to fight this plaque. One way is to create a material that just kills the bacteria. So at the beginning, it kills the bacteria, and at a certain point, some bacteria are able to cover it, and once they cover the first layer of the plaque, then it's gone. The other way is to have materials or peptides that signal the bacteria, don't stick to me, just keep going. This is much smarter way, because then you don't kill the bacteria, you just signal to the bacteria, don't stick to the surface. And there are some creatures in nature that have this type of peptides that allow them to stay sterile, especially some creatures in the depth of the seas. So if companies will be able to take this type of peptides, artificially create it, and then layer whatever is the material, titanium or zirconia or maybe a different material, I think that this type of developments will be very beneficial. But I have no doubt that there will be companies that will come with some antibacterial surfaces for the abutments at least. I am not sure that you need it for the implant itself, because once you have osseointegration and you have the bone that is not compressed, and as I show you in 10th of situation, the bone is even covering on top of it, what I need is just to prevent the accumulation of plaque on the coronal part of the tissue, which is the coronal part of the abutment or the cervical component of the crown. And for me, if these developments will be able to be clinically implemented, this is a big step forward to start reducing the peri-implantitis and peri-implant mucositis situations that we see around.
With the lingual and proximal site of the crowns on the implants, do you think our architecture for it needs to be a little bit changed with the more concave surfaces to apply more tissues on the proximal and the lingual that indirectly will help with the dental papilla to slide a little bit more buccally, or you don't think it will matter much?
Well, for me, it's very easy. The deep part needs to be as narrow as possible. So this is a circular, it's a circular part, because circular part is the narrowest possible configuration.
Yeah.
To have thicker band of connective tissue. Then when we come close to the margin where we want to start having the shape of the natural tooth,
reverse X.
I can easily over contour my crown proximally, because the papilla there can be condensed towards the adjacent tooth and the underlying bone, and nothing will happen. I cannot over contour it too much labially, because then I will stretch the collagen fibers, and collagen cannot be stretched. It can be condensed, but it's a molecule that cannot be stretched. So this is why in the anterior part of the mouth, we thicken it to have enough tissue that we can a little bit modify. And I
Very valuable.
prefer to do it on the model. I can do it also chair side, but it takes too much time. I don't want to spend the time of my patient and myself. So I'd rather have excess of tissue in the model, carve it to the ideal shape, have the cervical profile at the ideal shape, matching the peri-implant envelope, place it in the mouse and let the tissue adapt to it. It takes several weeks, months, but at the end, you get very nice results.
It's stable, it's vascularized, it will grow.
That's right.
I love the way you think, Dr. Bichacho. We all were very impressed with the lectures and the work, and we're very, very honored and happy to have you. And
It was my pleasure.
no, it's an honor, really. Thank you. I think everyone enjoyed it immensely. Look at your smile now. Look at this smile.
There's a reason behind that smile.
Because
We've been doing over 80 webinars, actually, presentations from all the different disciplines in dentistry. And today, we just saw a miracle. This presentation has been shared over 300 times, and we had the highest numbers of people that have been live, including the father of dentistry, the modern dentistry that was on. You have higher numbers here. Can you tell us why people love you so much, Dr. Bichacho?
I'm not sure they loved me, but I think that
yes, they do. We all do.
Post-COVID-19 Sunday, it's a good time.
No. It's you, Dr. Bichacho. Like, we all love you and we love
do.
your work.
You're very well respected.
I believe that once we get some insights and we accumulate knowledge, it is our duty to share it with our colleagues. Nothing should be kept in your own head. And I believe that once you spread whatever you believe in, that helps your colleagues, and they try it, and they see that it does work, then it is the most beneficial reward that somebody can get.
Well, let me give you an idea of what you just started. We surpassed 1 million colleagues reached a few days ago. With the numbers that are just coming in that I'm seeing, you just put us on trajectory to reach 1.5 million doctors and colleagues from across the world. So what you did today perpetuated that extra push and it made it happen. Doctor, we really thank you for your contribution to this peer-to-peer project, which was initiated, as you know, with the top 100, where you were quite supportive and helped us and guided us, and then subsequently agreed to do this lecture for the Global Interdisciplinary Summit. We are highly honored. I'm sort of out of words here. Thank you so much.
Thank you very much, Joseph. Thank you, Kelmore.
Thank you, Dr.
God bless you all wherever you are.
Thank you. The way you blended art, science, and literature, and beautifully and artistically is just is amazing. It's beautiful.
Have a great day. Thank you so much for your time and this wonderful presentation, the hosting and all. And I think it's approaching starting to be nighttime in Israel as well. I wish you a good evening and good night. And we shall see you at a future program, Doctor. Thank you.
It's a pleasure, Dr. Bichacho.
Bye. Shalom. We say shalom.
Shalom.
Bye. Salam.